Thank you for everyone that joined and that's joining. My name is Alex Carrillo. I am the CEO and founder of Alcar Health. We are a trusted network of advisors and solution providers that specialize in servicing FQHCs. We've been doing this now for almost 16 years. We've had the pleasure of working with FQHCs across the state of California, from the border all the way up to Sacramento and across a few other states. So we appreciate everyone joining today. With that, today's webinar is really focused on the topic of extended hours. What happens after community health centers close their doors at 5 or 6 p.m. and what can possibly be done to serve those patients. So that's what we will be talking about today with our guests. So as more people are joining, thank you for joining. We appreciate it. With that being said, I would like to introduce my friend and business partner, because we do work with Primetime Health really closely, Dr. Nathan. I've had the pleasure of knowing Dr. Nathan now for a couple of years, and he is the CEO and founder of Primetime Telehealth. He has a really strong background in FQHCs and started a service that when I came across it, I always wondered, why didn't someone think about this before, right? Why now? But I'm glad he did it. I'm glad his team's doing it. So we've had the pleasure of having him agree to do this webinar to educate everyone on the model and just things that they've learned and doing this service. So with that being said, I would like to introduce Dr. Nathan to everyone. We'll let him introduce himself and then jump into the webinar.
Thank you, Alex. I appreciate the introduction. Thank you, everyone, for joining me on this webinar today.
Dr. Nathan, before you jump in, if you wouldn't mind just giving us a little bit of background on yourself, that would be great.
Over the last 3 years, I've been seeing patients from community health centers in the evenings. And through those 3 years, I've learned a lot. Before I started Primetime Telehealth, I was an associate medical director for a federally qualified health center in California. And this was the time of COVID. So I got put into the deep end really fast. But it was a really good opportunity to learn everything. And the key takeaway that I mentioned to Alex before is that theory got thrown out the window. We can sit and theorize, but when something like a pandemic or patient safety and care is involved, then we have to start implementing and be more actionable. Of course, we want those to be safe and legal, but there's always opportunities to grow as you are actively doing the workflows. Patients will give you feedback, your team will give you feedback, and with that feedback, we can always optimize your workflows. And so during COVID time, during the time as an associate medical director, I kept seeing a problem that kept coming up. It was patients needed care beyond traditional 8 to 5. And that's when I went out and built Primetime Telehealth. It made sense because we thought patients who couldn't get in to see their PCP during those hours, who had work, who has caregiver needs, who had school, they weren't able to get the care that they needed. And so I built Primetime Telehealth to give access to those patients. My goal with today's presentation, it's titled, Everything Was Working Until the Patient Got Involved. Because of patients, we can't have nice things. I'm joking, but, nice things as in nice workflows, because not every patient goes through those exact workflows. And we have the unique opportunity over the last 3 years to see 25,000 and more patients through the extended care that we provide. And those patients have been selected and filtered, and they end up with us for a particular reason. And that's the reason that I'm going to talk to you about it. So when we started, we set out to start telehealth after hours. It just seemed intuitive. We thought we'll see a lot of patients who had acute needs, more like an immediate care, more like an urgent care. And we wanted to answer the question of what happens after the clinic closes. Diseases and patient needs don't say, hey, it's 5 o'clock, our shift is over, and they don't stop affecting the patient. This isn't like Inside Out where you just check out and you're gone. So that's where Primetime Telehealth started. The idea wasn't to replace primary care or build another telehealth company. It was really to extend the access that community health centers were providing the patient. Nothing revolutionary, just better access to care. We expected to see a lot of medication issues, UTIs, infections, illnesses that were appropriate for managing through telehealth, primary care needs, of course, and review results. And that's what we designed Primetime to do. However, it's after we started seeing more and more patients that something started to show itself. Almost every patient had a story about everything that happened before that visit. It wasn't, hey, I have a concern today. I'm going to call the doctor's office, get an appointment because it's convenient for me. It was more, I've been trying to get this refill for the last 2 weeks. My referral expired. I can't get through to anyone. I sent portal messages. My pharmacy sent messages. No one is picking up. And my PCP isn't available for another 3 months. These were all different complaints. They were different patients and different sites, but they all started to sound very similar. So real quick, before we get going, I wanted to ask the audience, what do you believe is the number one reason that patients are seeking care outside their PCP's office? Is it because they have an acute illness, a lack of appointments, administrative barriers, or convenience? So I do see acute illness is high, convenience is high, and the lack of appointments and administrative barriers. That's great. I think lack of appointments kind of brings everything together too. For acute illnesses and other convenience, they still need an appointment. So each clinic will have their own reasons. And what we've seen from our services over the last 2 years was that everything just kind of falls into lack of appointments. And that makes sense because what lack of appointment really means is there an appointment that's available for the patient when they're ready to get that care? Going to the doctor's office, and I can speak as a patient and as a provider, sometimes it's a gamble. It's not an unstressful event. Even though we try to create workflows to make it as unstressful as possible, patients, when they think of going to the doctors, they think of sickness. They think of potentially getting a diagnosis that they're not expecting. You can have a patient who has a simple cough that leads to become something else. You can have a patient that does their lab work and discovers something that surprises all of us. So it's a gamble for patients. So having that mental space to be able to say, okay, I can handle this. Let me go and see my doctor. That doesn't happen on a fixed schedule. And that happens when patients have a need and have the availability. The other side of the story is that usually PCPs have panel sizes of 2,500 to 3,000 or even more patients. And as there's turnover, more patients get added to their panel. If you were to calculate exactly how many available slots these PCPs will have in an year, it's around 4,000 to 5,000 slots. That means that a lot of these patients can't get more than 2 visits. If some of them can't even get 2 visits, it comes down to like 1.9 visits. So you can imagine some patients may just need 1 visit, but a lot of patients need 4 or 5 visits to titrate medications, for follow-ups, or medication side effects, to improve their hypertension. They need multiple visits. And so it makes sense that there are lack of available slots for these patients. Even us, we get wrapped up in our own work and the missions of running health centers that we don't always have time to take care of our needs as well. And then there's the other side of the story, because when I see a patient, in my mind, during that visit, I'll tell the patient, hey, I'll see you back in 3 months. I'll give you enough medications for 3 months. Sometimes there's no appointment that's scheduled in that time frame or for that 3-month time frame. So then the patient's calling because they're out of their medication. Now their next available appointment is not till a week or 2 weeks later, or potentially even further. Patients, some medications, maybe they can go on a few days without taking it, but there are certain medications that they need refills. So you can understand how this stress builds up. And those are the stories that we were hearing in the evening hours that we were seeing patients. So then we started to change the question that we were asking in our minds when we saw these patients. Before it was, what is the chief complaint? But then we started thinking, what happened before they needed us? Even before we think about that question, the patients would actually tell us. They would actually be a little apologetic. Hey, I didn't mean to bother you this time of the hour. I appreciate you working. I just didn't know where else to go. And we saw this story happen over and over again. So we wanted to make sure the data that we collected matched the stories that we were hearing. That's why we started to evaluate the 25,000 patient encounters. We did some of those individually, but also we did some computational analysis as well. We do use Physician UX, which is an AI-powered clinical workflow platform. It does AI scribing, it does telehealth, it does clinical intelligence. And through that, we were able to de-identify the patients and try to find stories and patterns that the system was able to pick up. That was based on sentiment, that was based on, the reason for the visit, which I'm going to share with you in a moment. And these were data from patients over in California and throughout different parts of California as well. When we reviewed these individually and when we shared the stories amongst our own team, we saw very similar friction again and again. It was things to do with medications. Most providers have the right intention. They put it in their notes, hey, I'm going to send this patient this medication, but something comes up and they just never fully do that. And so these patients end up with us. Patient providers sometimes forget to put the directions on the medication. try to forget to put the ICD-10 codes. The referral expired. They sent it to the wrong pharmacy. There was a lot of these individual problems that came to us to resolve, which was fine, which made sense. But we wanted to go even deeper. We wanted to see, is there something that is very unique to this patient population that they're seeking care outside of their normal hours? So then we wanted to identify who these patients were first, their age, their gender, and the main reason that they were coming in. To not so much our surprise, we saw that most of these patients were between the ages of 36 to 65, which makes sense because that was our original mission, to provide access to patients who are balancing work, family responsibilities, and caregiving needs. Taking time off for a daytime appointment isn't always easy for them. So this data reinforced the patients that we were reaching. And then we looked at the gender. We saw that the majority, more than half of the patients that we were seeing were females. And this goes hand in hand with normal primary care. There are more women than men that see regular visits. So at this point, we were confident that the population that we were looking at was a usual community health center population. So nothing unusual about the gender and really their age distribution. And then we started looking at, what was the main reason for these patients to seek after hours care. We expected it to be coughs, colds, and acute symptoms, and it was pretty tight at the high end, first and second place. But what surprised us was that medication concerns came up the highest. A lot of this was needing refills, being out of medications, not knowing where else to turn. And the reason that this was significant is that this is medication concerns is not really the medication itself. So when you need a refill on metformin, when you need a refill on lisinopril, it's not really the refill. It's really, hey, I want to talk to you about my hypertension. I want to talk to you about my diabetes. I want that care for my chronic needs. So when you look at medication concerns, it's a little bit of all of that. But in reality, we did see a lot of patients who just couldn't get an appointment to get a refill on medications. So let's see. So a lot of these patients, they still just wanted continuity of care. They wanted their primary care services beyond the traditional hours. It wasn't just an immediate care and urgent care type of practice. This was, I guess, pretty significant. The most common access barrier was that their PCP was unavailable, which also means they weren't able to get an appointment in a timely manner. That's really what it is. If they ran out of medications, if they have symptoms, then they needed to see somebody and the appointment wasn't available. The second most common barrier was reaching the clinic, sending messages, portal messages, the pharmacies calling, all these things. They just couldn't get to anybody. And then somehow they were able to get to the evening clinic and we were able to take care of them. These barriers weren't random. They were just surprisingly consistent across thousands of the encounters that we looked at. And then we looked at how long did these patients wait before they got our service. I guess, honestly, this was what surprised me the most. I would think that most patients would call the day that they got sick, or they call get an appointment when they first realized that they had their medications were run out. Only about 16% of the patients had symptoms that started within the 24 hours. Nearly one quarter had been dealing with their problem for more than a month before they saw us. When you add it all together, more than half of our patients had been living with their concern for 4 days or longer before they finally connected with the clinician. I remember one patient saying and apologizing, saying, "This is not an emergency. I understand. I just need someone to help me." And we see that story a lot, different versions, but the same sentiment that we get from these patients. And of course, medication access is the top concern for patients because our job as clinicians is to insist that patients are compliant, that they need to take their medications as prescribed. And when that doesn't happen because of access issues and communication problems, that leads to a lot of confusion in patients. Some patients assume that, hey, I didn't get a refill, so maybe I don't need this medication anymore. Or some patients think, hey, if it's not important enough for my doctor to refill my medication, then maybe it's not important for me to try and take it. So we've seen that a lot. So when you put all this together, what you see is that you have patients who can't get an appointment with their PCP, they need a medication question, and they've been waiting for at least 4 days. And that is what we learned to be the most common type of patients that we saw. And this was the point that everything clicked for me. The problem wasn't that patients wanted evening telehealth. The problem wasn't that they wanted to avoid their primary care provider. The problem was that somewhere along their journey, getting the care they needed had become difficult enough that they looked for another path. That changed the way that we started thinking about these visits. And then as I looked through these journeys, I started asking myself a different question. If our evening clinic hadn't been available, where would these patients have gone? And you can see on this diagram that patient has a concern, they're not able to see their PCP, then they'll send messages to the portal, call center, reach out to the pharmacy, referral department, insurance, all these things. We did catch a lot of these patients with the clinics that we work with. But if this wasn't here, then a lot of these patients would just loop around the different categories here. Eventually, they would see their PCP. But at that time, the PCP would have to deal with an unhappy patient and a patient who may have had care in so many different settings that the information is very fragmented, and they just wouldn't be able to compile all that together and get a real state of the patient in that moment. Some patients would have probably waited a few more days. Some would have gone to the urgent care, the emergency department, and some would have just done nothing and continued without care. So what became clear is that our after hours clinic wasn't creating demand for the evening, was actually creating demand that otherwise would have gone somewhere else. Another way to say this is we weren't competing with the PCPs or the primary care team. We were competing with the alternatives patients choose when primary care isn't available. I have another question. Which administrative challenge creates the greatest burden for your organization? And I think it's going to be unique for each organization. Referrals and authorization, that's what I expected. Because even as a medical director, that's a problem that I was trying to help solve for a long time. And no one really has control over that. So the patients don't really know who to follow up with, when to follow up. Am I waiting for something? Is the referral being processed? So there's usually a lot of concerns about that. And then patient, these are all very good. And it's interesting that the medication refills wasn't as high on the list. And the truth is we think that the system is made to catch that already. If the patient needs a refill, they can send an inbox item, they can send a patient case, they can request it from the pharmacy. But when you're on the front line, you realize that a lot of this is refill requests. When we actually see the patient in the office, that's not the issue. It's the patients whose request is sitting in the inbox, or the patient who had their pharmacy send a request, but there's no real way for the pharmacy to contact us that it's causing trouble. So I'm glad that I was able to point out that the medication refills, it sounds simple, but it's actually, very important issue that needs to be brought up to people's attention. To my attention, it was brought up, and I brought it up with other clinics as well to make it easier. Because we know provider burnout with all the inbox items. So if you're seeing 30 patients a day, plus you get one or two inbox items or like half of those patients, it easily adds up. And then that gets ignored or gets delayed days, and this patient is waiting without those refills. So we weren't replacing primary care. Almost every patient already had a great relationship with the community health centers. What we were doing at this point was just giving them another option. Instead of leaving their medical home, they can stay connected to it. That's why I don't think of Primetime Telehealth as an evening clinic anymore. I think of it as a bridge back into primary care. Now, with all this being said, what if we were to find the friction earlier? What if we were able to map the patient's journeys, the ones that end up seeing us, which is great because we keep that within the system. And a little bit more challenging would be, how did they end up in the emergency room for a simple cough? Why did they go to the urgent care for UTI? Why couldn't we see those? So if we study those and we see those frictions, we can actually reduce the number of administrative challenges or tasks that we get. So instead of 5 phone calls, instead of 2 refill requests, instead of 3 portal messages, and instead of 1 grievance, we actually have journeys that look at these individual patient needs. When we look at also all these new services that are coming out, all the new technology that's coming out, we have to also think about, is this going to reduce the friction that a small amount of patients are experiencing in the clinic? You can, if we want to generalize, you can say that the majority, let's say 70% of the patients can go through the system pretty easily. But the 30% of the patients who demand more of the system, who expect more, or who need more of the system are the ones who use up a lot of the resources. So any solutions that we think of, any solutions that I built myself with my team, we think, is it going to help these patients who find the most difficulty in navigating the healthcare system? So that was the end of my presentation. When I started Primetime, I thought it'll be an urgent care, immediate care clinic, but it turned out to be something different. We looked at 25,000 patient stories. Each patient had 2 different stories. One was the medical story and one was the operational story. And with these operational stories, we saw patterns. From those patterns, we got insights. And then hopefully those insights can help us improve the way we care for our communities. So I really appreciate everyone's time. I'll hand it back to Alex. And if you have any questions, I'm more than happy to help.
Thank you, Dr. Nathan. I don't know if we have any questions at the time. I'm going to ask a few questions from the patients that you and your team engage with. And I might have missed it, but did you see any pattern where this was the first time they were having a telehealth visit, or was it something where they're used to having telehealth visits?
A lot of the patients, they were getting comfortable with telehealth visits. They were happy that there were telehealth availabilities, but more and more the services of telehealth were being pulled back from the patients. The health centers wanted patients to come in person more than do telehealth, and that bothered patients, especially those ones that we see, because they needed that convenience, and it wasn't out of any selfish needs. That's just the only time that they can get care. So some of these patients through COVID experienced telehealth. They saw the convenience. They saw that these clinics were putting together service that was meant for them, and then all of a sudden it's being pulled back. And then when it's being reintroduced again, they're grateful. They see, hey, I understand my PCP is busy. I mean, I see him. I see his waiting room. I see how he's running around doing all these things. I don't expect him to be available at 7:30, but that doesn't mean I can't get my care. So they're appreciative when they do get access to somebody that can take care of them. And then they're like, thank you for your help. And then they go back to their PCP. And usually we end up end the conversation saying, hey, your PCP, he's doing a great job. He's taking really good care of you. But just know that we're here to help you as well. So we're here to support the PCP.
Right. And I think what's different, and I know, this was more about showing your findings, but I think your model allows for that, right? Where when they're coming to Primetime Telehealth, the patient doesn't know who Primetime Telehealth is, right? For all they know is I'm seeing Dr. Nathan or Dr. Wells or Dr. whoever it may be that's part of my clinic, right? So that I think allows for the care coordination to now leave that health center and it's all controlled in that health center. Otherwise, it could be where, they feel like they're going somewhere else and then coming back to you. This is just kind of I'm curious, when these patients are connecting with you via telehealth, typically, where are they? Are they at home? Are they in their cars? Are they still at work? Where are they?
Honestly, all of the above. And,
Really?
Sometimes patients would have an appointment at 8 p.m. And then I would try to get them to come in a little bit earlier, but they're like, I don't finish my shift till 8. Mm-hmm. So that's the only time they could make it. We're thinking here, patients have done their job at 5. That's not always the case. They might need until 7 or 8 to be able to actually get the care. Patients would be in their car because they're in between their shift. They might have a night shift and they're sleeping during the day and then they need to go to work. So in that gap, they're in their car. Obviously, we tell them to make sure they're not driving and they're parked. That's where they are. A lot of patients are at home. And the convenience of being at home is that we can use that time that we save to really get to know the patient, really look at, how we can titrate the medications, we can reconcile the medications, we look at quality measures, preventative care, we can have a deeper conversation. And with my background in lifestyle medicine as well, we trained all my team to make sure we're coaching these patients, make sure we bring them back into caring about their health. Because we know that if we can get them interested again in their health, they'll come back to their PCP, they'll take their medications, they'll do all the preventative care needs that they need to do. So that convenience of being able to do it where it's comfortable for them gives you a deeper conversation and connection.
I can appreciate. I've done it. I've used telehealth quite a bit. And for me, it's always been just finding time during the day to go, right? Even though I control my schedule, if I could do it via telehealth, I would do it via telehealth because it saves me time, it saves me the drive and so on. I guess one of my last questions is I remember this was before I was still maybe a teenager. And I went to the doctor, didn't have insurance. I was paying cash because I didn't have insurance till I was 30 something years old. And I remember walking in, and I'll never forget that doctor. I remember walking to the clinic, and to this day, she traumatized me so much. I can't remember why I was even there. I walked in, and I told her what I was there for. And I was so intimidated, right? Because I was not used to going to a doctor. And then once she started to pay attention to me, I said, oh, by the way, I'm also fitting this. And I'll never forget, she told me, we're here for this thing. We're only going to talk about this thing. So if you need that, you need to make another appointment. I never went back, right? But I think for me back then, it was intimidating, one, to go see a doctor, right? And then when I was there and I started to feel a little comfortable, I wanted to share the other problems that I had, right? So do you see that with the patients, right? Like now that they finally got access to a provider, do they go in for one thing and start opening up about other things?
They do. And that's usually okay. We have the time. I mean, that's the benefit of telehealth. But I'm not saying telehealth is more important than in-person exams. The only reason what we do works is because they have a PCP, because they have a whole
Right.
continuity of care and someone to do that in-person visit. Without that, I wouldn't be doing what I'm doing. So we know that we have that time to let the patient really express themselves. And we always end the conversation with, is there anything else? But then at that point, we have to triage it as well. So if it's already taken 15 minutes to talk about their initial need, and now they're coming in with another need, I usually tell the patient, hey, this sounds really important. And I think that we should give this
Mm.
need the time that it deserves. So why don't we schedule another follow-up to talk more about that? I think if they feel listened to, and if they know you spent that time talking about their initial problem, and they can also see, hey, yeah, I guess I did kind of bring this up at the very end. It's not fair for anybody here. And they're more than happy to. So it's really how you talk about that. But at the same time, and this is some things that I talk about with provider burnout. Providers are not burnt out because of all the problems that the disease medical problems that they're solving for the patients. The providers get burnt out when there's administrative problems that they just don't know how to solve. I don't want to not know something that can help the patient. But when some things are
Sure.
not in my hand, it creates a lot of tension. And when a patient comes in with a lot of administrative problems, that drains me. But if they had medical problems and they're like, hey, I have this symptom too, it's like, hey, bring it on. Let's talk about this. This is interesting. This is being a detective. And this is something that I can eventually get to an answer to. But when it's administrative challenges, it makes it a little bit harder.
One question is, how do you envision telehealth evolving from a convenient access point into a more integrated part of patients' overall care journey?
I think it's kind of going that way. I think patients are taking more control over their health. We know that patients are signing up for telehealth even outside of their community health centers, so teledocs and Lilly, and trying to get medications that they think they need. So patients have already started to find their own means to get convenient care. And I think as we move more towards value-based care, telehealth and asynchronous communication is going to become more and more important. I always say the story of everything else in life you get on demand, pretty much. You need a driver, you get a driver. If you need food, you get food. If you need groceries, you get groceries. If you need a toothbrush, you can get it within like 1 hour from Amazon. Why does health have to be different? I mean, health is so important. Why do patients have to wait weeks to get that service? And so with telehealth becoming, over time being proven that it does help when it's combined with in-person visits, I think it becomes more and more integrated into their own journey.
Yep. Thank you for sharing that. We have one other question. It says, have you tracked or observed any impact in quality opportunities, such as completing annual wellness visits or other care gaps?
We've worked with different clinics to do annual wellness visits. We know that AWVs can be done remotely as well. Some of these clinics do have the patients come in person, and then they connect us to the video in the room. So the patients who can't get on the call with annual wellness visits, we're talking about patients possibly 65 and older. So when they can't get on the call from their home, they'll come into the clinic and they'll set up a laptop, and then I'll see them. That gives us more information as well. And then that also helps the medical assistants guide the patient on what the next steps are. You need this screening tool, you need this screening done, you need these labs done, you need to go see the specialist. So through that, we were able to build a pretty good annual wellness visit program. I think when you take that out of the normal 15-minute visit time slots that we see in the clinic and look at it independently, it helps build out that system. And then we've done quality programs where patients who haven't had their A1Cs done this year or in the last 3 months, and who are automatically set to be uncontrolled and A1Cs over 9 just because they haven't done it. We've done panels of those patients who we talk to and get them to come in and get them to get the labs done. And we were able to improve the measures through that way. There are also programs where we worked with our remote patient monitoring. So for blood pressure, we were able to titrate the medications. We were able to provide education to the patients, and with their home blood pressure machines, we were able to document the new blood pressures because it's RPM. We're able to document within the EMR. And so those blood pressures show as controlled. So it helped with that. So we have programs for individual quality measures, and we work really well with the clinics to get those.
We have one more question that just came in. Are the telehealth visits documented in the health center's respective
Yes, yes. So we pretty much join as a medical group with the community health center. So we become a team of providers that will be on your schedule. We'll have your team add patients onto the schedule. We'll get credentialed with your managed care plans, your payers, and then we'll get access to your EMR. Our clinicians are trained in multiple EMRs. We're used to doing different ones, so we know what the most important aspects of that EMR are. And with my background in clinical informatics, we're able to kind of look at where to put quality measure readings, where to get data from other resources if they're connected to HIEs. So we're able to kind of build on that and use that EMR. But ultimately, with physician UX and the AI scribing and everything that we have, we take that information and put it into the EMR as a note within your own system so that your PCPs can see it, and everyone that's involved in the care can see, hey, what was this discussion really about?
When you're using physician UX, right? Obviously, it's recording and it's taking the notes, it's putting it into the EHR. Does the health center have access to those recordings afterwards to, because a lot of times I want to know exactly what was said in that visit, right? Is that something that's available to them?
This is something that we build to improve the workflow for providers themselves. So all the tools are aimed towards provider satisfaction. And so we don't record any of the conversations. We have a transcript, but the transcript is encrypted and only the provider can decrypt it and see it themselves. We actually don't give access to all the administration to see those unless the provider shares them for peer review or anything like that. Ultimately, because we work with different EMRs, we didn't integrate into one particular EMR. We keep it outside the EMR. It sits on top of it so that it's easy to work with different EMRs through that system.
Got it. I guess another thing you brought up on how you get credentialed, and once you're credentialed, you're working with an FQHC, a health center. What's that collaboration look like with the providers that are there, right? Because your team is remote, their providers are on site. How does that collaboration work? How do you guys make that work?
Yeah, and honestly, it's a mixed bag. I mean, you have some providers who are really excited about our help and they're happy that there's a team-based approach to this patient's care. They're happy that when they go on vacation, they're not coming back to unhappy patients or an inbox full of requests that no one had time to attend. And then there are some providers who are very protective of their patients. Very few, but they're very protective and they feel that other people shouldn't do anything within their providers and they don't trust telehealth. Maybe just speaking from a bias, I think that just taking away a mode of treatment for that patient. I mean, I don't think it's fair to tell the patient, hey, I don't think you should participate in this program, even though the rest of the health center is participating. And of course, we know what visits are telehealth appropriate. We work with the health center. We send them our list and the questions that we want them to ask when they're scheduling the patient to make sure it's appropriate. And we're able to gauge even during the visit, hey, is this something that I really feel safe doing over telehealth? But that doesn't mean I'm going to just hang up the phone with the patient or end the call. That's still an opportunity to talk to the patient. It's an opportunity to see, hey, okay, so this patient is having stroke symptoms. I'm happy that I was able to see them. I'm going to tell them to call 911, get a caregiver there nearby, call 911, get them to the emergency room. I mean, it's not always that obvious, but even things like, hey, the patient has swelling, they're having this cough, their weight has gone up, a lot over the last few days, they probably need to go to the hospital at this point. So these are situations that otherwise would have been missed. And if they didn't have access to just getting seen on telehealth. So for example, last few weeks, I've been covering a provider who usually, goes and sees their family in another country. So I've been seeing all their patients, and this is during the daytime as well. So my team can see patients during the daytime. When this provider knows when they come back that these patients are going to be taken care of, they're not going to be upset. He's not going to have a huge list of inbox items that he has to take care of. And we've done that a lot. That makes me happy because then I get to support my colleagues.
Makes sense. Dr. Nathan, I don't think we have any more questions. I don't have any questions. Appreciate you sharing this with us. I think it's great information for the organization serving the population that's most in need. Thank you very much. We appreciate it. I want to thank all of our attendees, everyone that joined today, thank you for attending. We hope you found this helpful and informational. We will be, it is recorded. We will be sharing it with everyone. So once again, thank you, Dr. Nathan, and thank you everyone for joining.
Thank you, everyone. I appreciate it.
All right. We'll see you guys. Thank you.
Thank you.